Hello everyone, welcome to today's webinar. My name is Hannah Crouch, editor at Digital Health, and I'm pleased to welcome you to our latest best practice webinar, which will look at all things digital remote monitoring across the NHS. In particular, what is being done in this area and how this is transforming the way we care for people. This ranges from care being given at home to virtual wards, the patient journey from population health analytics to identifying cohorts to shared care records and supporting integrated health and social care. It covers quite a lot. So today I'm joined by Roma Holland from NHS Coventry and Warwickshire Integrated Care Board, Bilal Kamani, a cardiac surgeon from Liverpool Heart and Chest Hospital, Adrian Flowerday, who's Managing Director of Docabo, and Rob Howellhead, who's the Chief Operating Officer at Docabo. Now, before I hand over to our lovely speakers, just a quick reminder that after our presenters have spoken, we'll then have the main Q&A session. And just a reminder, if this is your first webinar or your last or one that you've attended for many, just a quick reminder that if you do have a question, you can ask at any point during the webinar, and please do get your questions in. It makes for a really good discussion, and you know, it's just your opportunity to put any questions that you might have. Best place to do this is in the Q&A section. Sometimes they can get lost in the chat, so please put them in the Q&A box at the bottom, and you can also vote for your favourite questions. So if you like the look of it, give it a thumbs up. And if you would like your question directed to anyone in particular, please let me know, and then I can direct them. Otherwise, it's a free-for-all. I'm now going to stop talking, and I'm going to hand over to our presenters.
Thanks, Hannah. I really appreciate that, and it's good to see everyone here this afternoon. I've got a great audience today. Hopefully you can see my screen now. So yes, you should see it properly, right? Okay. So good afternoon, everyone. Yeah, like I say, we've got a great audience from a very wide kind of background joining us today. So it's great to have you all here and to share a little bit about some of the work that's been going on. Like Hannah said, I'm Adrian Flowerday. I was founder of Doc at Home about 22 years ago. It seems a lifetime, but it is a lifetime almost. I've got Rob Howellhead with me, who's our Director of Business Development. And I'm really excited to have Roma Holland from Coventry and Warwick, and Bilal Kamani from Liverpool Heart and Chest. So it's really good. And they're going to share about their work. They've done two quite different areas of need that they've been involved with implementing remote monitoring. So I think, firstly, I just wanted to set the scene really, and just to kind of put this in the right situation, and just share a little bit about on one or two slides about kind of what we're talking about today. So remote monitoring, Doc at Home is the name of our remote monitoring platform, and the remote monitoring platforms are all very similar in many ways. Doc at Home has a range of different what I call in-patient kind of interaction options, so ways that patients with different cognitive and technical abilities can interact with the system and be able to enter vital sign data, symptomatic data, and to also be able to view self-help information, to be able to view videos, educational videos that can be streamed down to the devices. And that's about people in their own place of residence, and that could be at their own home or could be in a care home. Doesn't matter, they could be on a cruise if they wanted to be. But the idea is the range allows and ensures digital inclusion by allowing different ways of allowing people to interact with the system. And then the data eventually is then viewable by clinical teams, and they can be a whole host of different clinical teams across the system. And some particularly the triage hubs would come into our own vWards clinical system, which is a web-based tool, or more and more we're seeing a lot more interfacing with shared care records, with GP systems, and with electronic patient records. So that was a quick overview. And I think the thing about remote patient monitoring is that, you know, it's more increasingly used. People who understand it a lot more, even though we've been doing it for years. I think COVID really accelerated the awareness of remote monitoring. And as I put there, it's used across long-term conditions. It's used in virtual wards more and more now, and in care homes. And we've seen a lot of success in all of those. But the challenge is how to move to scale, and to realise those benefits. Because if you just give 10 or 20 or 30 out, you don't really get the scale. So, and I think the main thing is what we've been learning is we need to try and identify the appropriate cohorts for remote monitoring, because some it's not suitable for, it's not the right thing, but in areas where it can make the delivery of care more efficient, then it's a good tick box. So it's how do we identify those? And I think with the ICS structures that come in place and the need and policy around getting integrated care records, shared care records aligned with those ICSs, I think we're starting to have the tools to be able to do that. And to share a little bit about that, so you know, we're looking at trying to do a population approach at cohort identification. At the moment, a lot of telehealth is a GP may think of someone to refer to the system, or a respiratory community nurse may think about, oh, this person needs to go on remote monitoring. Well, obviously we're missing out a lot of people there, and we need to try and get some consistency in there. So what we're getting now with the ICSs is obviously the shared care record, where we're getting data coming in from lots of sources. Then it allows a population health layer to go on top, and I'm sure a lot of you are involved in these areas, where we can start to think about focusing on those groups of patients that need telehealth and remote monitoring. So it's around looking at those, slicing and dicing the data, applying filters to create cohorts. And then we've got cohorts, we can put them onto remote monitoring, and there's a whole lot of different areas we can do that there. But I think the key thing is around that, as we're monitoring, is that actually that data is then available and to be shared and viewed in the shared care record. So all clinical teams have access to shared care record, can view the clinical data that we're recording from people from their own homes. And also that then feeds into population health and helps the analytics and understanding of what's going on, and helps the evaluation. So we've got some tools there that are doing that, and that really enables us to do fact-based commissioning. So not just based on some assumptions, but fact-based commissioning. We can commission services, and we can get fact-based outcomes from it, because we've got information that population health allows us to identify. We've got our intervention going on here, where we've got data coming in from patients, and then the results can feed back into population health. And I think the key thing around that is around precision cohorting. If you get the right cohorts, then you will maximise your return on investment on the technology there. So that's really important. Now I'm going to hand over to Roma Holland now. I'm hoping Roma's on.
Thank you very much for inviting me today, Adrian, to present the work that we're doing at Coventry and Warwickshire. So if we move on to the next slide. The programme was set up really to look at a remote solution that would care for the people in their own home or their place of residence, but also it was in anticipation for the integrated care system. So it was ensuring that the social care services were fully integrated into general practice and out of hospitals as well. So that was the aim and the purpose behind this. Initially, it was about the enhanced care home DARES, but we soon realised that actually we could move this out towards long-term conditions. Next slide. So you'll see in this slide that we have set up a strong governance process by which we ensure that we're providing assurance to the social care services, but also to the healthcare services, which includes our organisation partners such as the acute trusts, the out-of-hospital teams, the partnership trusts, and also the social local authorities teams. And then you'll see in the grey slides there, care homes, community, acute and mental health. Underneath those, we've got task and finish groups that we set up by PCN. So the PCN clinical director sits and chairs those task and finish groups. We include on the membership DOCABO, the programme management team, as well as the lead GP clinician, and we work through the pathways and we look at the data question sets that they will be asking their patients. So we ensure that each PCN feels that they have a handle on the design of the remote monitoring service that's going to be fit for their patients. So we make sure it becomes a local initiated programme. We have a programme board that covers the whole of this programme, and that includes finance, contracting, commissioning, local authorities, out of hospitals, general practice, and also that feeds into our Ageing Well Assurance Board, and then that goes forward into our Urgent and Emergency Care Board. So there's a full assurance process and governance that goes behind this programme. Next slide. These are the work areas and the work streams that we have included on our programme. We've done some health inequalities, and we've looked at our population health across the footprint of Coventry and Warwickshire. And these were the areas that we felt would benefit the most from having a remote monitoring programme. Next slide. We've developed a dashboard, and although it looks quite busy in this presentation, in actual fact, it has a wealth of information that we provide on a monthly basis to the programme board and then feed into NHSE. You will see in the top segment, that's all about our care homes. And you will see that we've got on there the number of patients that are active, and we also will have on the bottom row, you'll see the previous month, so that we can do a comparison on how many additional patients we're adding within month, which is our reporting mechanism back to NHSE, our regional programme. Below that, you will see the patient's own home, which is our long-term conditions, which is that bottom column, and they're the patients with COPD and heart failure. We've currently got that deployed across Warwickshire North, which has a population size of 200,000. So we've got a percentage of COPD and heart failure, and we've got it in one PCN in South Warwickshire, and we've got it in the whole of Rugby. We're now starting to deploy that in Coventry. Next slide. We've also created a dashboard because, as my next slides will show you, all our alerts are fed into the out of hospital clinical hub. Most areas call it the ICC or the iSpa. We've renamed it as part of our brand to call it the clinical hub. In there, they receive all the alerts, be they the green, amber or red, and they have an escalation flow chart they use, and that tells them the type of care that patient's going to need, whether it's a telephone triage call only, or a telephone triage and then a response from a community nursing team, or whether it needs to be escalated to a hospital. So we have these stats that we accumulate on a monthly basis, and again we can feed back. It tells us how many GP slots we're saving at general practice. It also tells us the turnaround time within the 2 hours, which is the Ageing Well target. We know that we are recurringly now achieving a 96 or a 98% turnaround time from alert to an intervention from either a telephone triage or a call. So we're meeting that 2-hour target across our system. Next slide. At the moment, we're very much focused on virtual care, and this shows you here what our clinical hub actually offers. All the alerts are triaged by a band 6 nurse, then they have the telephone call or clinical input as required. They have a disease-specific questionnaire set, and these are all managed on a framework of the SBAR. We have the News 2, My Patient is Unwell, and this ensures that there's a rapid management of patients who are clearly demonstrating that they're going into an acute phase. And our community nurses, we know now, have averted many of those patients escalating and having to go into hospital. If on a telephone triage, they feel they need to use the advice and guidance, which is a telephone call into a consultant, a respiratory consultant at our local hospital, we've also integrated that into our pathway as well. And that ensures that those nurses doing the home visits actually are getting clinical consultant support as well as general practice support. So we're fully integrating in here now. Next slide, please, Adrian. Our next steps will be to start supporting the virtual wards that are going on, and we're looking now, having developed the pathways, at how we can support the early discharges, but also we're now looking at the escalation and the de-escalation. So those patients who are on virtual care, if they deteriorate, we're looking to see how we can move them from virtual care to virtual ward, but initiate an early discharge because that patient's already on the remote monitoring. So we believe, and it's a test of concept, that we can discharge them earlier because we can still provide the ward, but in their own residential environment. That is consultant-led, but again, it's very much a collaboration between general practice, secondary care, and out of hospitals. Next slide. The next few slides, which will be shared with you, I'm sure, are just a snapshot of the patient surveys that we receive from Docobo. So every 12 weeks, the Docobo system generates a questionnaire set for our patients so we can assess the actual benefit to the patient. So rather than us try and construct and evaluate what we expect the benefits will be for the patient, we're looking for the patients to indicate to us actually how that service needs to evolve and develop. Next slide, Adrian. And the next one after this. And the next one after this. So there you see some of those evaluations that are actually sitting on the remote monitoring system, and they go out, they're self-generated every 12 weeks, but we're starting to do some great analysis on that now, and it's really giving us the benefit to the patient, which we haven't had access to before. So our vision for the future is to continue with our system-wide approach to deploy the remote monitoring out. We've currently got about 3,300 residents on there in care homes, learning disability care homes, and also long-term conditions. We're only halfway through our PCNs, so we expect by the over the next 12 months that we'll have a further 3,000 on. So we are scaling up at pace. We're also scaling up the long-term conditions. We're currently moving through the heart failure, and we're trying to get that done at pace because obviously winter is upon us. And the palliative care is certainly showing that there are benefits to our patients and our health professionals. We're looking to expand into a real remote monitoring solution, which is for mental health patients. We're looking to actually put the system into a mobile unit and actually drive around to do the annual healthcare checks, but also do some other healthcare benefits as well for the patients, and look to see if we can develop some questionnaire sets that in actual fact means that rather than go into our partnership trust outpatient area, they can just use this remote monitoring system to answer the questions and to use that system, which may be preferable to them. And I think that's my last slide, Adrian. Thank you.
Yeah, thanks, Roma. That's really good. And thank you for that quick overview and all that, those interesting facts. It's amazing how the work has kind of exploded there in Coventry and Warwick. I believe we're celebrating soon our 100th care home on the system. So that's really exciting there. And yeah, it's all part of the team work as well. It's a good team. It's a focused team. It's a top-down team. It's a commitment from senior management, and it's a commitment obviously all the way down to do that. So thanks Roma for that. Really appreciate that. Can I now hand you over to Rob Howhead to say a few words and introduce Bill? Thanks, Rob.
Thanks, Adrian, and thanks, Roma. Yeah, so my pleasure just briefly to introduce our next speaker, Bill Kamani. Bill is a consultant cardiac surgeon at Liverpool Heart and Chest Hospital. Liverpool Heart and Chest, as you may know, is one of our larger centres for cardiac and thoracic care. So it's the largest single site specialist hospital for heart and chest in the country. Unusually, it's been twice rated as outstanding by the CQC, and and it is the centre of excellence. So Bill is leading the cardiac surgery waiting list triage project. Next slide, please, Adrian. And he kicked it off, and his standard operating procedure, or SOP, has been shared and adopted by the 3 Northwest tertiary cardiac centres, and as you can see on the map there. And Blackpool in particular going very well. So it's an interesting project. Now the collaboration between the 3 centres is one of the pleasing aspects. It's so good to see. And Bill deserves the credit for being the catalyst for that. It may have helped a little bit, of course, that he spent 6 months at Blackpool after he qualified, and he spent 6 months there in a fellowship, and he was studying minimally invasive cardiac surgery. He's a bit of an expert. By the way, he's also got a sense of humour. So with that last point, I will hand over, and Adrian, I think we need to switch over to Bill.
Yeah. So I'm going to stop sharing. Stop sharing. And then, Bill, hopefully you've got the...
Yeah, well, thank you very much, Rob, for that glowing introduction. Your check is very much in the post, although I suppose with the digital technologies that we have, I really ought to have just done a PayPal straight to you. So for everybody who is in the audience, if you can pull out your smartphones, I'm going to be one of those awkward speakers who actually wants you to have your device out, both to scan the image. So if you haven't done this before, if you just point your smartphone camera at that QR code, the camera should give you a web link to go to, and that should open up directly. If you are still on a Nokia 8210, if you can just close down the Snake application and go to some form of web browser, you should be able to get to the same place by going to polev.com/Bill K. And hopefully there'll be a little bit of interactivity just here for your engagement. And I'm going to be talking very briefly about how we've done remote monitoring for cardiac surgery here in the Northwest, so Cheshire and Mersey, as well as our adjacent neighbouring networks who we're working with. So going to talk about how to identify patients and which patients we want to keep involved, and hopefully you have got. And as you can see, as that time stretches on and you get that awkward silence, people start to move from being comfortable to being awkward. And that's exactly what happens when somebody is waiting for a cardiac surgeon to do something. Why telehealth for cardiac surgery? Well, this graph is probably one of the most important graphs that we have in our specialty. And I'm going to break it down for you in just a second, but it essentially shows what happens when you've got aortic stenosis, which is one of the different forms of heart disease that patients can develop. And you can have severe disease for many years. And as you can see, over a 20-year period on this graph, even though the patient might have severe aortic stenosis, they might not have any symptoms, the body compensates, everything just carries on as normal, and life expectancy stays about where it would be if you didn't have the disease. And then, all of a sudden, all of your compensatory mechanisms run out, and the body can't compensate anymore. And that's when you get symptoms. and that typically is when patients enter the NHS referral process. They go to their GP, the GP sends them to a cardiologist, the cardiologist does some tests, and they end up being referred to us for their treatment. But surgery doesn't happen straight away, and in between referral and their curative surgery, they are stuck on a waiting list. And as you can see, the decline with untreated disease is really quite severe once the symptoms start. So you might have a 50% chance of being dead within 2 years if the treatment isn't sorted. So that's 25% in a year, or 2% a month, roughly, of attrition to that population who are waiting. And that decline on the waiting list is really where telehealth comes in. So imagine that that's you, or that's a family member. You might be waiting 6, 8, 12 weeks for this surgery because the NHS is so swamped trying to recover from COVID. Operations are being cancelled because there's no beds. What would you want? What would you want to happen to you while you're on the waiting list? And obviously, the thing that everybody wants is their operation to be done sooner. But in the absence of that, what would you have? So you should on your regular contact. Yeah, absolutely. Managing and monitoring, and it, you know, unfortunately, one of the problems with regular contact is that takes, personnel, it takes nursing staff, it takes doctors, and part of the reason that we're so overwhelmed is because there's so many patients waiting. So that's really difficult to manage. Patients are constantly informed about the dates, and they're constantly shuffled around. And obviously, all of these things are coming down to being kept informed, being given regular checkups and opportunities to monitor the condition, and opportunities to use that time in a productive way rather than in a fallow way, and absolutely to keep your symptoms as good as possible. Because it's a 10-minute slot, I'm going to let you keep on putting those in, but I'm going to move on just for information. So obviously, what we're talking about here is providing intervention and insight, both to the patient and to their treating clinician. And this is what we get. Oh, a little bit of echo there. Was that a question? No. Okay.
No, I think carry on, Bill. Don't worry.
All right, no worries. So this is there's the schema that we came up with, and I'm going to again break it down for you. So don't worry about how many bits of information there are. So typically, what would have happened, so a few years ago, is that the patient would have been referred to the surgeon, would have been put on the waiting list, and the next contact that would have invariably happened is the invitation to come in for their operation. So what we do is, once we've got the patient on the outpatient waiting list, so they've been seen in the clinic, we put them onto the telehealth program so that right from the onset, they know that there's going to be that monitoring, that communication, that insight. And the telehealth program that we've got breaks down into 2 main parts: prehabilitation, which we'll come to in just a minute, and symptom monitoring. And for the vast majority of patients, you go onto the system, you participate in the information collection, so monitoring your symptoms, your observations, your blood pressure, your oxygen levels, etc. Nothing really happens. You get some advice on how to be best fit for surgery, and you go ahead and have your operation. And that is what we would hope most people would need. But it's for those group of people whom the monitors trigger that red alert, the amber alert, where you think that there's a potential deterioration here that may end up in that patient being one of those patients who succumbs in those few months between being assessed and having their surgery, where you can evaluate what's going on. You can optimize them either through the general practice specialist nurses, or escalate them to treatment. And then in the post-operative phase, you can also use telehealth to help with their rehabilitation. This is a little bit like Roma was describing about having the ward at home, taking the expertise of the hospital into your own house so that you can get home sooner, and then any complications can be monitored and hopefully prevented, nipped in the bud. So the patient is really very much the focus of this, and the prehabilitation is also key, because as well as monitoring and intervening with complications that arise both before and after surgery, we want to be able to try and prevent them. And things like dietary advice, exercise advice from physiotherapists, smoking cessation from health professionals, psychology or psychiatry input to try and get you in the right mental preparation for what is really a very arduous, physically and mentally challenging operation for the patient. Diabetes control, because that can massively improve your outcomes if your diabetes is well controlled. Lung treatments such as enhanced chest physio, chest exercises to make sure that your lungs are in the best place possible to cope with this big operation. Peer support, including support from specialist nurses and from other patients who may have been through it or are going through it with you, to try and best prepare you. And obviously the monitoring. And with the monitoring, it's some of the things that you've already heard about just now. So one of the things that we want to do is measure the observations, the sort of quantific measures, blood pressure, oxygen levels, weight, those sorts of things. But also importantly, things like symptoms, because those are key to understanding the rest of the data, and things that are newer and we perhaps don't have a great understanding of, such as step count and activity levels. So a lot of people feel as though they shouldn't be doing exercise if they've got a serious heart condition, and actually it's exactly the opposite. The more you sort of exercise the heart, like any muscle, the stronger it gets. Those all key into a central hub, and that allows specialist nurses to assess that information and triage it into the appropriate place. So if that means going to your local hospital, or going to speak to your GP, or just getting advice from the hub itself on what to do next, then that's fine. Or if it looks like we're seeing an early deterioration that can be dealt with, it comes directly to us via a specialist team, who can then make sure that the operation proceeds in a timely fashion. So Rob already kind of presented this. Cheshire and Mersey is our local population. It's 2.7 million people, 18 NHS trusts, 355 GPs, and 9 local authorities. And as you can imagine, a single specialist centre like ours wouldn't have the resources to do everything that we've talked about just there on a one-to-one physical face-to-face basis, which is why telehealth is so important. When you add in the fact that we also deal with referrals from North Wales and the Isle of Man, and national referrals for some of our specialist services, and the collaboration that we've got with the local trusts that we work with, it's clear that the only way that you can do this is with a degree of robotic automation, which is why it's been so important for us to link in with our partners, Docabo, who've provided the infrastructure and the ability, and also the insight as to how to deliver this cardiac surgery program in a way that is ultimately, hopefully, going to be scalable across the country. Just one last question to you all. Hopefully you've found the interactivity element of this talk useful and interesting, but certainly for patients, even if they don't have any direct intervention as a result of their participation in the telehealth program, as you saw with Roma's slides, the sense of belonging, the sense of satisfaction definitely goes up because it feels as though something is being done. So even for the vast majority of patients who don't need any of the particulars of telehealth, we're finding that it certainly gives them that sense of confidence moving forward. That's great. Thank you very much. And I'll just hand back to you there.
Thanks, Bert, for that. I really appreciate that. I should be off mute. Yeah, hopefully you can all hear us. What I'm going to just bring up a screen, questions and answers, or we could just leave it at this, couldn't we? We could just have questions and answers now. Hannah, have there any questions come through? Or
yeah, Roma's very kindly answered one of them, but I was just hoping if she could say it kind of out loud. So there was a question about is data from the Docabo platform being transferred directly into GP and secondary care systems in the programme? Would you just be able to answer that, Roma, just so everyone can hear your answer? If you can hear us, hopefully.
Yeah, I can now. I can hear you all, and hopefully you can hear me. So if I did say any words that aren't PC, I'm very sorry, as the cat was attacking me. I didn't realise you could hear what I was saying. To answer the question, we are EMIS across the whole of our general practice, and we've also got EMIS hubs built into our ED, which is our emergency department, and also into our out of hospitals. We're just putting those hubs now into our hospices as well. So we've integrated Docabo into EMIS, so that actually it's fully integrated. There's a click button on their web browser that the GP practices or the nurses, the community nurses, can go into, and they can see the last 28 days. But it all then feeds back into the patient's record. And likewise, in the out-of-hospital hubs, they're getting the alerts coming through EMIS as well. So it all absolutely configures right back to the patient's full record, which is cradle to death. Now, going forward, we've got a Coventry and Warwickshire-wide integrated care record. We're partners with Birmingham and Solihull, Hereford and Worcester, and our expectation is InterSystems, that's providing that integrated care record. We're now doing the integration into that as well, so that all of the information on our frail elderly patients, our care home patients, etc., all of that rich information will be available in ED as well. We are currently looking to do and see if there's something there as part of our winter pressure management with our paramedics as well.
Perfect, thank you so much. And kind of just sticking with the GPs, I mean, what sort of benefits do you see for GPs from this project?
The benefits for their patients are they're seen under 2 hours. They have a 7-day service from 8 till 8, Monday to Sunday, and that's something their patients haven't had in the past. The care home staff can also provide benefits to their patients because the education that they receive to use the remote monitoring system, Docabo, has increased their skill sets and their knowledge. So when they have the conversation with the out-of-hospital teams, they can have an actual factual and clinical conversation because the data there that's in front of them. For our patients in their own homes, their families or their carers can also participate and see the information on the remote monitoring system. Again, those patients feel they're more secure because they get the 7-day 8 till 8 service from the clinical hub. And as they say, even though they don't think they need a phone call, they suddenly get a call from the out of hospital teams because they're showing on their alerts that they're starting to deteriorate. So patients have a great sense of benefit. They feel included in their treatment programs, and they feel that they're participating on any intervention that needs to be provided for them at that time.
Perfect. And just kind of one final one really is, questions came through is how have you measured benefits against standard care other than patient and professional impressions?
Well, we can see from a general practice perspective that we've been able to release a significant quantity of appointments back to general practice. So we feel on average we're getting 19 hours per month per practice that is released back to them. We are also looking to see how we can measure the benefit to the system as well as the patient. So we were asked to look at admissions into hospital, conveyancing through ambulances, and just see and treat at ED. But unfortunately, or fortunately through COVID, all the pathways have changed, and there's been the introduction of SDEX as well. So we can't compare our current data with 2019, which was what the expectation was. So what we're looking now to see is we're identifying when care homes went on to remote monitoring, and has there been any change in individual care homes from before and after. And we're doing deep dives into specific patients who've been admitted to do the analysis to see, was there a reason for their admission other than, was there a need? So it wasn't anything to do with remote monitoring. So did they fall, or, what other health issue has brought the admission? So we're looking at why they went in. Was it just for diagnostics, and did they get an earlier discharge because they're on the remote monitoring? So from a system perspective, that's what we're looking at the moment.
Bill, you've got your hand up. Do you want to add something?
Yeah, no, I think that's a really interesting point, Roma, because quite a lot of what remote monitoring does is it prevents problems, doesn't it? And it's really difficult to measure something that hasn't happened, especially when the comparator group that you ordinarily would have had is a historical group, which is typically very different to the one that you've got at the moment, because a lot of the move to telehealth is as a response to COVID, which means that our current group of patients are in a completely different universe to the ones that existed a few years ago. And in trying to establish what the benefits of COVID, of telehealth are for us, we've really had to move towards doing a randomized control trial to say, if you take exactly the same group of patients and you give some of them telehealth and some of them not, is there a difference in the number of hospital admissions, the number of deteriorations, the control of diabetes, the rates of smoking cessation, etc. So it's interesting to hear you say that you've had the same issue with that benefits measuring.
Perfect, thank you. And I know there's been some other questions as well about, will we be sharing the presentations? And yes, we will. And also the session's been recorded, so you can, if you feel like you missed anything, you can watch back. Another question we've had through from Sid is saying, in the case of cardiac patients, how is manual remote monitoring mitigating the risks of sudden cardiac arrests or cardiac changes? I'm guessing that's one for you, maybe, Bill.
So how is manual remote monitoring mitigating the risks of sudden cardiac arrest or cardiac changes? So there's a number of things. Firstly, trying to guess at whether we can prevent a sudden cardiac arrest is difficult. But what you can do is you can find very subtle differences in observations and symptoms, perhaps activity levels, etc., that might herald a sudden deterioration. This isn't something that has been routinely available for us. So we've gone into this as fairly new territory. And one of the benefits realizations that we're hoping to find is that we identify more patients who score amber or red alerts, so the things that surgeons normally worry about, before the patient presents at an A&E or with a collapse or with sudden death. So the answer is we don't know yet, and that's why this is also interesting.
Perfect, thank you. Another question, which I think is one that kind of always crops up when we talk about kind of any sort of digital health project or healthcare IT project, was how easy or difficult was it to get patients to sign up and engage? Because, you know, sometimes that can be a hurdle. So I'm not sure for Bill and Roma, from each of your perspectives, how kind of easy or difficult was it to get them engaged?
You go first, Bill.
It was really easy for us because patients are acutely aware of how dangerous their conditions are, and any opportunity to have additional contact with hospital services seems to be very, very welcome. So they all seem to jump at the chance, and my concern, as Rob will remember, before we started out, was that we were, because by definition patients with severe cardiac disease will have been developing it for a long time, and therefore at the older age spectrum, I was worried that there might not be engagement for the 70-year-olds, the 80-year-olds, the ones who didn't grow up with all of this tech around, and actually they're very happy to participate and they're very engaged.
Yeah, I for our long-term condition patients, because again, we started off during COVID, that they welcomed the system, and in actual fact, because we had project team that were able to go in, so we seconded an advanced nurse practitioner to actually go in and do the hand holding and do the training and to demonstrate to the patients in their own home. And then we have the utilisation data that we get on a monthly basis from Docabo. And if we see a downturn in the utilisation, we'll go back in and just see, you know, what is it that they're struggling with and not to use the system. So we've had an interesting journey on that. Initially, really welcomed it, a little bit anxious because of it being technology. And again, like Bill, it was that age group. But in actual fact, they soon got to grips with it. In care homes, that was more problematic. There was a level of resistance initially because they were more concerned about the indemnity element with regards to, you know, should the information be incorrect. But we were able to reassure them on that and give them the legal position. So all in all, since then, we're actually now getting the PCNs coming forward and asking to go onto the system, and when can they get onto the plan. And we're actually having patients now in rheumatology and in respiratory going into acute trust saying, I've heard about this remote monitoring system. Can I not go on this? Do I have to come into hospital? Can I not just give you my readings? So we're starting now to get a complete change. We've got a big comms plan that we're going to do, and a big strategy as we get our 100th care home on, and we're hoping to do a piece on the BBC. We're going to do some social media and some local media coverage on that, and we're also now engaging with Healthwatch. So as the patient's voice, we're going to start asking them to champion this as well and drive it through their groups and their links. And we're also reaching out now into patient participation groups to ask them to champion this through as well. So I think it's just using all communication systems to make everybody aware that it's there, and that's how you drive the change.
Perfect, thank you. And then Rob and Adrian, from your perspective at Docabo, I hope I'm saying it right. I think I said Docaboo the other day, but it's definitely Docabo.
we don't mind. We don't.
I think I was getting too much involved in Halloween. I suppose one of the hot topics, you know, that we cover extensively on digital health is, you know, interoperability and kind of being able to view data from other clinical systems. So what kind of plans do you have, if you do have any, for Doc at Home clinical users to be able to view data from other sources? Because I'm guessing that kind of feeds into when we're looking at things like ICSs and this whole idea of sharing data. Kind of, are you able to share anything?
Yeah, thanks, Hannah. I think the word interoperable probably comes up on every tender, and by the questions that are asked under that banner, there's a whole wide range of what people are wanting or expecting, and trying to clarify what people really want around that. You know, we need to do a lot more work around use cases. You know, is it about just dumping data everywhere? I don't think it is. It's about transferring knowledge, information, rather than just data. I mean, we've been obviously involved in several interoperability things. We're signed up to the interoperability charter for Tech UK, and NHS Digital in England were behind that. So we're very keen on being interoperable and making our data shared. Obviously, we're doing the work in Coventry and Warwick on the intersystem shared care record to make that data available. The thing is, with remote monitoring data, you've got your vital signs, that's kind of coded data, but then you've got a lot of symptomatic questions that local teams can develop and have tune into their local requirements. And they're not diagnoses per se, they're just someone's how they feel today from a symptoms point of view. So it's around how do you code that, how do you display it in another system. So there's a lot of considerations about that. But I know that the NHS England transformation team are looking at this now, and to try and make it, particularly with the virtual wards, how can we get a standardized set of data into the EPRs and everything, and there's a program of work just started on that. So yeah, there's some exciting stuff. I think it's still early days, but it is very much what do people mean by interoperability. Yeah, for, you know, maybe a GP wants the blood pressure readings for QoF, you know, or but does he want every 2 blood pressure readings every day from a patient put into a system? Probably not. How would we want to look at that and maybe put some average readings in? How should we calculate those average readings? So there's a lot of kind of detail behind the word interoperable. But I think my view is, you know, a bit like if on a shared care record you can see an X-ray or something like that. The X-ray doesn't come in; it's linked to the hospital system. That's the way I see it: is sharing the views rather than moving much of the data.
Thank you. 2 questions have come through on the subject of care homes. So I'm not sure who wants to jump in. So one of them is asking, do the care homes fund it themselves, or is there incentives for them to support the implementation? So I'm not sure who feels equipped to answer that one.
Could be Roma.
Yeah, I can answer that. So we were fortunate enough to be awarded a regional NHSE bid, and therefore, as it stands at the moment, it's currently funded through that bid. So the care home staff, they don't, so the care home owners don't fund any of this at all. Local authorities, as it stands, will now start to participate in the funding of the solution, but that's because we've now become an integrated care system, and that's been driven by NHSE. But other than that, at the moment, it's being funded as a test of concept through the regional programme.
And then kind of another question saying, was there any resistance from care homes or any care homes? What was their kind of response?
There has been resistance. They've not all been easy. Some of them have received the training, etc. And then we've had to go back again. There's times when we booked them, then they've had outbreaks and we've had to rebook them. You know, that's our business. We manage risk. And that's what I consider all of that to be risk as part of a programme, and we just have to manage it and work with it. We did put in place an escalation process by which, if they were resisting 3 times, the local authorities would write to them and they would ask them to confirm how were they managing my patient is feeling unwell, and could they confirm to provide assurance what it was that they were doing alternatively to the remote monitoring solution. CQC meet with us now on a quarterly basis because they're also engaged in using the remote monitoring to do the News 2 or the deteriorating patient assessments. So they're asking as part of their annual assessment, are you using remote monitoring? And if you are, what are the benefits? So they're really looking into that now to see if they can move that onto part of their criteria for the ratings that the individual care homes are getting. Some of the care homes that have been using it now for 12 months in Warwickshire North, the owners have other care homes in South Warwickshire, and they're now asking why can't they have the same system in South Warwickshire as they have in Warwickshire North. So again, now the proprietors who were initially resistant are helping us to get it deployed out elsewhere. So I think it is just a case, give them time and they come with you in the end because they can see the benefits.
Perfect, thank you. I think we've got time for just a couple more questions. Another question has come through from John saying, any thoughts on remote monitoring of cognitive health? Not sure who wants to take that one on.
I can tell you what we did here. Cognitive health is, I suppose, a slightly difficult one because you rely on a degree of cognitive ability to engage with the system, and otherwise you're devolving onto carers or advocates to do that. So we considered it, and it's obviously something that's really important, but we kind of probably swayed more towards psychological well-being. We also put in questions about fuel poverty and food poverty as well, to try and be a little bit more holistic. But cognitive health was a challenging one and probably not as directly associated with our area of interest. So we didn't engage with it as much as we initially hoped that we might do.
Perfect,
Yeah, I could just add a comment on that as well, Hannah.
Yeah, of course.
It's an area where we've had a mix of involvement over the years. And of course, some of this is a common comorbidity when you're talking about long-term conditions. One of our clients ran a trial to see if they could get early warning of people having a deterioration. And I think it was quite successful. And that's an area where we aim to do a bit more work. And there are several people asking us now and want to engage because the whole field of mental health is massively under-resourced. And there are probably people occupying mental health trust beds who could probably be supported partly by the technology. Just throw that in.
Perfect, thank you. And then just one final question we have got, obviously, before we wrap things up, is from Amanda, and it's kind of going back to that whole engagement thing, is how do you engage staff who might feel reluctant to change, particularly hospital staff, etc. So, you know, what's your advice on engaging, you know, that kind of sector of the workforce?
Shall I jump in first? Is that right? Thanks.
You kick off, Bill.
So this was actually a really significant concern because we had a really massive multidisciplinary team of nurses, physiotherapists, particularly the people who would have done hands-on rehab, dietitians, diabetic specialist nurses, and traditionally, as with medicine, you would have done everything face to face. You get a flavour of what you're dealing with by seeing the patient, seeing how they walk in, by meeting them, the words they use, things like that. And there was concerns that if you made a poor judgment call based on the information that you had, that there would be repercussions. But actually, what we're finding is that nationally, there is a move towards using more telehealth because it's a case of either we don't deliver anything at all. So a lot of services have been sort of pared back because there's not the staff, there's not the physical resources to deal with the workload. So you just pick and choose who you think that you can get through with the time frame and the resources that you've got, or you use something like this that is different and may not give you the same fidelity of information, but only because it's so early on. And as we learn more and more, hopefully that will be better. But you know, having a governance structure that takes into account that those are the sorts of decisions that we're having to make, and having national mandate from sort of legislative bodies has certainly helped.
And then just to follow up, because I mean, hopefully this will be the last one. Did you need to upskill staff? There's always kind of this whole thing about making sure that staff are sort of equipped with sort of these types of changes. Was that something you had to do?
So in the same way that when the iPhone first appeared, people just picked it up and used it because the interface had been really well designed. I think one of the main things that I have been a thorn in Rob's side for over the development of this is that we try not to make it the staff, the users, the patients who need to learn the tech. It's the tech that evolves to become intuitive, and all credit to Docabo. Every time I've come with, a complaint about, something really minor, like a font size for patients who might have visual impairment, the response has been like, yeah, we'll get that sorted. And that's how you do it. You engage with the technology for the benefit of the patients. So the upskilling is really being very minimal.
Perfect, thank you. I think unfortunately our hour is up, but so there's not really much left to say. It's gone very quickly, I have to say. So I think we're going to have to wrap it up there. Thank you to everyone who's tuned into today's webinar, and thanks so much to our panel for all your presentations and the Q&A session just now. Just a quick plug from me: if you have enjoyed today's webinar, please head over to digitalhealth.net and go to our events section. We have plenty more events. We've got webinars, journal clubs, regional events. We also have our in-person events. So please head over there and register for plenty more. That's my plug over, I promise, and my little bit of marketing. So there's nothing left really to say other than thank you to everyone for joining, and that concludes today's webinar.